Hi, everyone, and welcome to episode 102 of the Veterinary Behaviour Chat podcast. So, today I thought we would chat a little bit about fluoxetine. And that is because I think fluoxetine is probably one of the most commonly used veterinary psychopharmaceuticals, certainly recently, right? So I think whenever we're thinking of a long-term medication, fluoxetine is the one that comes to mind first. And there are a couple of reasons for that. One of them being that we have a veterinary licensed formulation for fluoxetine, which is Reconcile. So that's definitely one of the reasons, especially in those countries where we are having to look at cascades, follow, any kind of cascade. So in the UK, for example. So that definitely is one of the reasons. But also we've got quite a lot of evidence. We've got quite a lot of research on fluoxetine. The Reconcile studies were pretty comprehensive. So Reconcile is actually licensed for separation anxiety in dogs, doesn't have a license in cats. But there certainly is a veterinary formulation out there for it. So I thought we'd kind of chat through fluoxetine a little bit, like what is fluoxetine? When would we use it? What are the things that we need to look out for? So fluoxetine is a baseline medication. So it's one of those medications that we think about giving for the long term to create a foundation of psychopharmacology, especially for pets that have generalized behavioral presentations. And the ones that we think about most are fear, anxiety, phobia, impulsive behaviors, high emotional arousal, aggressive behaviors, abnormal repetitive behaviors or compulsive behaviors. So it has a pretty wide indication. And it certainly, if we're trying to create sort of a long-lasting foundational effect, it's a really good class of medication or a good medication that sits within a medication class that is really good to think about. And this medication class that I'm talking about are the SSRIs, so our selective serotonin reuptake inhibitors. So there are a few other medications that also sit within that class, so paroxetine, sertraline, fluvoxamine, escitalopram, and citalopram. So those are the ones that we commonly think about. But of those, I think certainly fluoxetine is the most commonly used. So how does fluoxetine work? Well, being an SSRI, they all have one thing in common, and that is to selectively block the reuptake of serotonin back into the presynaptic neuron. And they do that by blocking the serotonin transporter. So by blocking the serotonin transporter, less serotonin gets reuptaken into the presynaptic neuron, and you have more serotonin available to bind to receptors. So that is kind of the first main action. And that's the action that all of the SSRIs share. But then each of the SSRIs has a slightly different, perhaps secondary action or some slightly different secondary actions. So fluoxetine is also a mild noradrenergic medication. So it has mild effects on the noradrenaline reuptake transporter. And one of the really interesting effects that fluoxetine has is that it's a 5-HT2C antagonist. So the 5-HT2C receptor is a postsynaptic receptor that serotonin binds to. And so fluoxetine is an antagonist at that receptor as well. And that becomes important later when we start to talk about side effects and what kind of makes fluoxetine fluoxetine. So the uses I've already spoken about has kind of a relatively wide indication. So again, fear, anxiety, phobia, panic behaviors, aggressive behaviors, high arousal, high impulsivity, aggressive behaviors, urine marking in cats is a really good one. And there is a really nice paper by Pryor et al. From 2000 that kind of looks at that. And then we sometimes think about kind of if you want to have sort of a quick mnemonic to remember that by, you think about fluoxetine F. So fluoxetine first, that's one of the things that we think about. So fluoxetine is oftentimes the first I guess, baseline psychopharmaceutical that we reach for. But then we also think about the F in fluoxetine standing for fast, frenetic, and furious. So I often think about fast and furious. Now, furious maybe isn't a great term, but if you think about those kind of high impulsivity, high emotional arousal, and perhaps frustrated or aggressive behaviors, that's where that sort of furious piece comes in. But it's oftentimes animals that show very sort of, I guess, movement related anxiety behaviors. So that kind of pacing, moving, hyperactivity, hypersensitivity could be another use. And there is actually a paper that has a much higher dose range for dogs that show these sort of hyperkinesis, hyperactivity, and hypersensitivity type behaviors. So it's got a pretty wide indication range. So let's talk about side effects next, because that's oftentimes something that most clients want to know about, and also obviously you as the professionals. So the first thing, though, before we get to side effects is, as with many of our baseline medications, whether that is an SSRI or a TCA or an SNRI, they have a little bit of lag time until full effect. So usually we talk about 4 to 6 weeks until they start becoming truly effective. Now, the side effects, on the other hand, you might see quite quickly. And if you are part of my psychoactive course, or if you're interested in why that is, there is a section in the psychoactive course in the long-acting medications where I talk you through the neurobiology and the neurobiochemistry of why that is. Like, why do the SSRIs take 4 to 6 weeks to take effect, but why do we see the side effects quite quickly? So if you're interested in that, psychoactive is definitely a good course to go for. So some of the side effects that we see most commonly are lethargy and changes in sleep pattern. Now, sometimes that's quite a nice side effect, especially in these very active, very fast, very busy patients that really struggle to settle. Sometimes the changes in sleep pattern, i.e. more sleep, can be quite nice. And sometimes this kind of lethargy or sleepiness can also be quite nice. And those side effects usually come from the binding of 5-HT2A receptors. So it's the 5-HT2A receptor binding that is responsible for those side effects. Then we can see GI side effects. So that could be vomiting, diarrhea, but sometimes also the reverse. So constipation, reduced appetite is a really big one. And that comes from binding to 5-HT3 and 5-HT4 receptors. So those two serotonin receptor types oftentimes have GI or cause GI side effects. And then we have this fluoxetine specific side effect, which can actually be increased activation or agitation. So sometimes these patients can actually seem more anxious than before, more restless than before. And that often comes from the binding of that 5-HT2C receptor, so that 5-HT2C antagonism. So that's a really important fluoxetine specific side effect to be aware of. We don't normally see that so much in other long-term medications. We can sometimes see that with trazodone, which is a short-acting medication, but certainly for the long-term medications or the baseline meds, fluoxetine is quite specific or quite unusual in that 5-HT2C binding and that activation or agitation we see. Now, sometimes that activation could be a positive side effect. So when used for depression in people, for example, that activation, that kind of motivation, or not motivation because that's more a dopamine effect, but that kind of activation, that sort of coming out of maybe a depressed state can be a positive side effect. In our pets, usually we don't diagnose depression per se so much. And where I see it certainly most is in that unwanted activation or increased agitation or almost seeming more anxious initially. Now, what do we do if we see those side effects? Definitely the first port of call would see how extreme are the side effects. Do we need to reduce the dose maybe, or do we even need to consider stopping? But oftentimes these side effects will go away on their own in weeks 3 and 4. So kind of a typical pattern is weeks 1 and 2, you would see those side effects. Weeks 3 and 4, those side effects might lift and go away. And sometimes actually caregivers can report things are getting worse in those weeks 3 and 4 because they actually quite enjoyed those side effects for their patient, that better sleep, maybe that being a little bit less busy, a little bit less fast. So weeks 3 and 4 is the lifting of the side effects, and then weeks 4 to 6 is the actual true anxiolytic and behavior modifying effects that start to come in there. Now, another side effect that we need to be mindful of if we have a patient perhaps that is a diabetic, that fluoxetine can cause hypoglycemia. And if fluoxetine is stopped, then we can sometimes see a rebound and we can see hyperglycemia. So that's something to think about. And then we want to think about interactions with other medications. So certainly monoamine oxidase inhibitors should not be given concurrently. And we'll talk in a second about if we were to change from fluoxetine to a monoamine oxidase inhibitor, so selegiline potentially, what we need to do there. So should never be given together with monoamine oxidase inhibitors. Also be very careful with any other serotonergic agent, because serotonin syndrome could be a potential risk here. So again, if you want to find out more about serotonin syndrome, there's a whole lesson about it in Psychoactive that goes deep into that. And then we potentially need to be careful about the concurrent use of non-steroidal anti-inflammatories. Now, practically, I personally have not seen a problem here. And I've also heard surgeons, veterinary surgeons speak to this. Veterinary surgeons that work in big hospitals where they also have veterinary behaviorists present, and where the veterinary behaviorists might be quite involved in the hospital side of things. So looking after the patients in the hospital from a mental and emotional health point of view. And those surgeons have never reported, or have not obviously reported, any complications that relate to the risk of increased bleeding when you're using fluoxetine and a non-steroidal together. So it is a potential side effect, something to think about. How really relevant and big that is in practice, I'm not sure. So something to think about. All right. So then we go on to our elimination half-life and all those sort of how fluoxetine is metabolized. Now, fluoxetine has an active metabolite called norfluoxetine. So when it is metabolized in the liver, it actually produces an active metabolite, so a metabolite that has effects, which is norfluoxetine. And one of the sort of specifics or individual differences of fluoxetine is that both fluoxetine and norfluoxetine have very, very long half-lives. So in dogs, the half-life for fluoxetine is about 6 to 20 hours. The half-life of norfluoxetine is somewhere between 48 hours and 16 days. So it can really have quite long effects. Now, this is both good and bad, and I'll talk about that in a second. The half-life in cats of fluoxetine is 48 hours. So again, pretty long half-life. Now, what is good about that is that we don't commonly see discontinuation symptoms or syndrome with fluoxetine. So if by mistake, for example, the caregiver forgets to give fluoxetine, or the pet is unwell and they can't get meds into them for a period of a few days, then that's not a huge problem with fluoxetine, because we have this long half-life. That's much more of a problem in some of the other medications that have much shorter half-lives, like paroxetine and venlafaxine, for example. So that is a really good thing about fluoxetine, right? That we don't have those discontinuation or withdrawal symptoms. Where the long half-life can sometimes be a bit of a problem is if we're trying to switch over from fluoxetine to another medication. Now, that could be any other SSRI, any other serotonergic medication, but particularly the monoamine oxidase inhibitors. So if you are considering switching from fluoxetine to selegiline, for example, you have to have a washout period of 5 weeks. Now, and that potentially can be quite a long time to leave an animal without medication for. If you are switching from fluoxetine to any other baseline medication, any other SSRI, or maybe a TCA, or maybe venlafaxine and SNRI, then usually a washout period of 2 weeks is probably enough. But with the monoamine oxidase inhibitors, that 5-week period is really, really quite important. We also need to understand that fluoxetine is metabolized in the liver. Now, we don't have any evidence at current to say that giving fluoxetine causes any long-term health effects. However, what we do want to know about is if there is secondary or concurrent liver disease, for example, we want to know about that because fluoxetine, as I said, is metabolized in the liver. And if there is liver disease present, that might change the rate at which fluoxetine is metabolized. So that's also something important to think about. One other thing that I just want to mention here as well is the cytochrome P450 system. So this is an enzymatic system that is very much also involved in the metabolization of not only fluoxetine and other veterinary psychopharmaceuticals, but a whole range of other medications that might be given concurrently. So if you have a patient that is on long-term fluoxetine and that is coming into the veterinary clinic for any other reason, for any particular reason, then you absolutely want to check your drug interaction checker, or you want to find out which of the medications are metabolized potentially by the cytochrome P450 system and what that means. So medications can either be substrates, or they can have effects on the cytochrome P450 system that either causes other medications to be more available or less available. And the same goes for fluoxetine. So if you've got another medication, if the pet is on another medication concurrently that has an effect, then there either might be more fluoxetine available than you would like, or than you would think about without that medication present, or there might be less fluoxetine available. So you have to always think about whether, what those cytochrome P450 effects are. Again, I talk about that in quite a lot of detail in Psychoactive. So if you want to understand more about that, then absolutely head to that course. I'm going to put the link in the show notes. And yeah, you'll find a lot more information in there. So I think just to recap, a couple of important points. Fluoxetine first is often what we're taught and told. That's certainly what I was taught during my residency, and oftentimes that's correct. Now, whether that's because of its individual effects, or whether that's just because we see so many pets with very common signs that fluoxetine is very helpful for, or whether it's because you are having to follow that kind of treatment cascade, fluoxetine is oftentimes the very first medication that we reach for, and we have a veterinary licensed product for it. So we need to understand what effects it has or how it works in order to understand some of the side effects that we might see. So again, that lethargy, changes in sleep pattern, GI side effects, reduced appetite, a big one there, and then that unique kind of side effect, which is that activation or increased irritability or anxiety. Remember about diabetes patients can cause hypoglycemia. Remember all of your other drug interactions, all your other serotonergic medications. Remember the half-life. It has a very long half-life, which can be very beneficial, but it also can be a hindrance if you're trying to swap onto a different medication. And then I haven't spoken about dose range yet. So I just want to be really careful here, because obviously dose ranges are ranges, right? And we want to be very mindful of that. And we want to make choices for each individual patient that is in front of us. And that goes for everything that I've said in this episode. But we would usually start in dogs somewhere between 0.5 and 1 milligrams per kilogram. We can go slightly higher with that. And then the paper, which I'm going to link in the show notes, by Bloyer, Elsner et al., talks about 2 to 4 milligrams per kilogram for those hyperactivity, hypersensitivity, hyperkinesis patients. So again, we really want to think about that. And sometimes we also need to go slightly higher in our dose range if we have abnormal repetitive behaviors or compulsive behaviors. So those would be the two situations where we might think about slightly higher doses. Now, in cats, again, we think about starting at roughly the same 0.5 to 1 milligram per kilogram. I rarely go much higher than that. Sometimes I go up to 1.5 milligrams per kilogram, especially if I have a large cat that has, that's kind of really impulsive, that shows these sort of high impulsivity, high reactivity, irritability behaviors. I might go up to 1.5 milligrams per kilogram. So that's a little bit of like a quick fire, rapid cheat sheet on fluoxetine. I will say that I have seen some absolutely game-changing effects from fluoxetine. When fluoxetine works well, it works incredibly well. And it has been a lifesaver, literally, for some of my patients. Now, we know with all psychotropic medications that sometimes the first medication we choose just simply isn't the right medication for that individual patient. And then we would, move to a different medication, whether we stay within the SSRI class or we maybe move to a tricyclic antidepressant or an SNRI. Really depends on the patient in front of us. But I would say, roughly about 7 to 8 out of 10 of my patients that I start on fluoxetine first, where I feel I have an accurate diagnosis, I have ruled out other physical medical causes of the behavior. And I have the signs, the behavioral signs that I think, fluoxetine would benefit. Probably 8 out of 10 of those patients where I choose fluoxetine first, it's the right medication for them. And, they have really quite significant, nice changes with fluoxetine. Now, delving deeper into all of that, what does it mean? Like, how do we know whether a medication is working or not? How do we change over? Again, I go into very detailed information, or I give very detailed information about that in my psychoactive course. So again, if you want to dive deeper into veterinary psychopharmacology, that's a really good place to start, or that's a really great place to go. But I think to give you a bit of a quick overview and a quick sort of cheat sheet on fluoxetine, I think I've given you most of the high points there. So I really hope that you found this episode useful. Let me know if you've got any questions. You can always contact me on social media. Go to Psychoactive if I've piqued your interest in veterinary psychopharmacology, or if actually by listening to me you want to know more. Head on over to Psychoactive. It really is a great, great course, and it's had loads of positive feedback. And in fact, one of the best bits about it are our quarterly Zoom calls, live Zoom calls, where we catch up and talk about meds. So I hope you've enjoyed this episode. I'm very much looking forward to seeing you for episode 103 next week. And I'm wishing you all a lovely week, and bye for now.